Got to give you the blow-by-blow so you know what's happening. And we are officially live. So welcome everybody. Good evening. Coming to you tonight from the New Jersey office of the HCMA and the California and the Pennsylvania offices of the HCMA and the program at Washington University, Barnes-Jewish in St. Louis, Missouri. So we are going to get started here in just a moment. We're going to let people populate the room, and we are now streaming on Facebook. If you are watching us on Facebook, some housekeeping tips: you cannot ask questions of our participants. All you will need to do is click on the link that Amy, if you can put it in the Facebook page when you have a second. So there's a direct link there to register if they want to join us in Zoom. Just as a reminder, it is December 2nd, 2021, 7 p.m. on the East Coast. So if you are watching this live, you can still join the live meeting and ask questions. If you're watching it later, leave your questions below and we will address them from the HCMA office. And if needed, forward them to our lovely faculty this evening. So without further ado, I'm going to introduce you. Now I'll stop our screen share here. I'm going to introduce you to the HCMA staff who's with us tonight. We have beneath me here, Julie Russo. Well, it's on my screen. Julie Russo, our volunteer coordinator, and Amy Mann, who now holds two titles, our meeting coordinator, as well as our HCM Academy coordinator. You're going to be learning about that later tonight. And I am really excited that we have the team from St. Louis with us. I think, Rich, I've known you the longest out of the crew, and that is probably almost 20 years now.
Oh, I think it's longer. I think it's 25.
I'm not old enough for that, Rich. I don't know what you're talking about. It probably has been since the very beginning of the HCMA back in '96. So, Rich, would you do us a favor and introduce us to your wonderful faculty?
Absolutely. Let me share my screen first.
Okay. There you go.
So I am really happy to be here tonight, and I want to express my gratitude to Lisa for all she's done. I have known Lisa since we met probably at the American Heart Association in the 90s. And
that's correct.
We've had a relationship since, and I really all she's done for the community of patients and families with hypertrophic cardiomyopathy over more than a couple decades. So we are fortunate here in St. Louis to be invited to have this webinar tonight. We hope we'll show you some interesting information for all of you participating. Welcome to, at least virtually, to St. Louis. Let me show you a couple of introductory slides. When we created our center, and it does date back probably about 20 years or so, I felt it was very important that we get together all the resources that were needed for someone and their family who had hypertrophic cardiomyopathy. So you'll see on this sort of wheel and spokes model that there are many different resources needed to help both evaluate and care for an individual with hypertrophic cardiomyopathy and extend that care to other relevant parties, such as their family members. So, but here, let me introduce you to some of the people here you'll be meeting tonight. Not everyone in our center was able to present tonight, but I want to tell you that I'm privileged to work with some very talented people here at Washington University and Barnes-Jewish Hospital. This is me in the upper left, and I do a lot of the clinical consultation in the office, but I'm also an interventional cardiologist here at Barnes-Jewish Hospital, and I've been doing alcohol ablation since the late 1990s as an intervention that I do find very helpful and very beneficial for some individuals who have this problem, hypertrophic cardiomyopathy. In the upper right, you'll see Dr. Sharon Cresci, and she is an expert in both imaging, echocardiographic imaging, and genetics, and you will hear from her a little bit later tonight. To the lower right, you'll see Dr. Marye Gleva, and Dr. Gleva is an expert in electrophysiology and our expert on the combination of electrophysiology and hypertrophic cardiomyopathy, where there are many intersections that are very relevant in managing arrhythmias, determining the need for ICDs, et cetera, that many of you are probably very familiar with. Very important, not with us tonight, but Justin Hardapy, one of our faculty members, is also a member of our advanced heart failure cardiac transplantation team. And for individuals who go down that pathway that they might need consideration of cardiac transplantation, we are fortunate to have Dr. Hardapy in our group. And he serves as liaison to the heart failure team and to the team who provide cardiac transplantation. And on that team also is Dr. Kotkar, who will be presenting tonight from our cardiothoracic surgery group. Dr. Damiano was originally scheduled, but he had an emergency, and so he won't be able to be here tonight. But we are very fortunate to have Dr. Kotkar, who came to us from the Mayo Clinic and who also has expertise in septal myectomy as a treatment for individuals with obstruction and hypertrophic cardiomyopathy. A couple of other faculty members who are not here tonight. Mustafa Husseini has joined our group recently. He also has expertise in athletes' heart disease, and so he's another welcome addition to our group to broaden the spectrum of expertise we have here to provide comprehensive care to anyone who has issues with hypertrophic cardiomyopathy or similar conditions. And Dr. Anita Bandawar at the top is one of our also clinical consultants who will see patients in the office with additional expertise in imaging, echocardiography, and cardiac MRI imaging. So we have a wealth of resources you can see here. And without further ado, I want to turn it back over to Lisa, who will be talking a little bit about navigating HCM over the next several minutes. Lisa, why don't you take over?
Thank you, Rich. That was a great overview, and I like the pictures. It makes it nice and easy. Okay, I am going to share my slides. Oh, that's what was happening. You were getting my Facebook feed. That was weird. I'm going to minimize that, and I'm going to go back here. And we will go to just, now I'm the one who can't share my screen. Okay, 1 second. Here we go. So one of those days, people, one of those days. Okay, so I wanted to take a few moments and thank our sponsors and acknowledge them. And I'm very happy to say that I got a note from Boston Scientific today that they will continue to be a supporter in the 2022-23 Bighearted Warriors Tours, as will all of our other sponsors. So we get to keep this train rolling for a couple of more years, thanks to their support. So some of you may have gotten this little postcard up here in the mail. If you haven't gotten your mail from the HCMA yet, please look for it. We sent out our annual giving campaign, so please remember to renew your membership. And if you would like to think of the HCMA during this holiday season, we would greatly appreciate it. All funds go to support our patient community. So this is our agenda for this evening. We are going to be covering a number of topics, including genetics and families with HCM, preventing sudden cardiac arrest. We're going to talk about surgical myectomy, and we're also going to talk about alcohol septal ablation a little. And we're going to get a really interesting update at the end of the evening about upcoming therapies and treatments for HCM. So we have a good program for you this evening, and we encourage you to stay along with us and watch it again on YouTube if you miss anything. Okay, so I need to tell you about an amazing new project. It's called HCM Academy. I'm a little excited about this one. I talked about it in last month's meeting, but it hadn't launched yet. And ladies and gentlemen, we have launched. What is HCM Academy? It is medical education provided by a faculty and consultants that is a free CME course that your physicians can take to learn more about HCM. It also includes a person-to-person segment where they will meet in small Zoom rooms like this to be able to have conversation and discussion from the experts in the field of HCM. So if you want to learn more about it, you can go to the website. We've launched 3 regions of the United States. Right now, we haven't launched the area that we're in tonight, St. Louis, but we're hoping to get additional funding for this program so that we can bring it to the entire United States. So You do not have to live in the region where you're getting trained. So anybody who's listening who would like their general practitioner or their hometown cardiologist to learn more about HCM, all you need to do is come to the website, and we're going to show you right here. Let me explain what that is. Here you go. You're going to go right to the website and go to programs, look at HCM Academy, and then you'll be able to press the refer your provider button. When you do that, you'll be giving us their name, their contact information, hopefully an email if you have it. And we will be reaching out to them to invite them to this free educational program. I kind of went out of order here because I wanted to tell you like what this actually contains. It's 6 online modules and 5 amazing HCM case studies with 5 amazing HCMA warriors featuring their stories as learning opportunities. And then the 1 online CME workshop. It's not coming soon. I didn't update my slide. I'm sorry. It is here, thehcmacademy.com, and you can go directly there. Or you can go through the HCMA website. That was provided with a financial support from BMS, Sanofi, and Cytokinetics. It is an accredited course, and the sponsors had nothing to do with the content. That was the faculty that you saw on the earlier slide: Marty Marin, Anjali Owen, John Lynn Jeffries, and myself. And we have built you a heck of an education model. So we hope everybody passes it on to their physicians. Okay, and if you're a physician watching and you want to take the course, just hit the provider button and you'll just go right in. So other big news from the HCMA, we are now live. This is a soft launch for this project, but we're going to be launching January 1, a very aggressive campaign to help change some legislation to enact laws that will add cardiac components to the well-child examination. Believe it or not, New Jersey is the only state in the United States with a requirement to ask about children's heart health in a well-child exam. That needs to change. And we're going to give you an opportunity to do 3 clicks of a mouse and you can save a life. So you'll go to the website, learn about the act, go to our online platform for advocacy, fill in the form, add a video if you want, tell your story in your own words, along with our letter and our request to your state legislators to write a bill, pass a bill, and save some lives. And it's simple. It doesn't have any cost associated with it. It is a bipartisan piece of legislation because everybody has hearts, and we want to make sure all families have an opportunity to discuss their heart health with their personal physician, and their personal physician to understand why it's important and make appropriate referrals. There will also be an education module in that program and that legislation that will require physicians to take a course. And I have support. It's soft support right now, I have to say, because it's not in paper yet, from industry that they will support the education model. And I'm looking for a 10-year support period. So we're working on that right now. So if we have industry support, the funding that would be required from taxpayers to have the education model, then the legislation requires that model to be taken. It's cost neutral. So it's not going to be a budget hit to anybody to do this. That is our intention. So we want to make sure that people know how to participate in that. You just click on the link at 4hcm.org/HCM-act/ and you're right there. So please do that. We are now currently recruiting, and you can go through the HCMA website volunteer tab. We're looking to add some committee members, which includes members of our faculty potentially and other medical providers. They're welcome to put their names in the hat for the committees. The legislative committee, we're seeking 5 new members. We've been a committee of about 5 already. We want to add 5. We've gotten a lot done, but we have a lot more work to do. The Patient Education Committee, we're seeking 6 new members. As these are already existing committees, we're adding to them, but we're adding a couple of new committees. A Health Equity Committee, we are seeking 10 members. I am currently seeking a co-chair for that committee as well. I am also building out our Medical Affairs Committee. There will be a certain number of slots for patients. The rest will be for members of the medical community. And we have right now, I think we've recruited 7 medical professionals. We're looking for 3 more slots on that. And that would be from Center of Excellence representation. So those positions are still open. Apply now. I want to take a moment to just talk about our Center of Excellence programming, a cornerstone of the HCMA. As of today, we have 43 programs in the United States. We are now working with our new, she started last month, Center of Excellence Coordinator, Stacy. She will be taking the very hard task of bringing the 16 applications in-house to fruition over the next few months. And we are also starting to work on our international outreach so that we can have our Center of Excellence programming model available in other countries. So stay tuned. I know India and Italy and the United Kingdom and the Netherlands and Australia are all ready to come on board. Oh, Canada too, but like they're Americans almost because, you know, they're attached, but they're nicer. So we're going to be bringing them on as well. If you're watching on social media, obviously you know how to find us there. We have a Facebook community that's quite large and robust. This is the page you're watching this program on tonight, but we have discussion groups, including our Parents Network, a general discussion group, and our international partners under our new HCMAI programming. And we have a Swedish group and a group in the Netherlands that speak in their own language, and they're tied to the HCMA, and we know them and they know us, and we're going to build a big world of all kinds of HCM support by the time we get done with this, aren't we? Okay. We have other online discussion groups that we're offering. There's offerings every week. All you need to do is go to our calendar and see what programs are available that week. So if you need some support, if you need some help, your peers are a couple of days away, hang in there, join a group, have a discussion, learn something, share something. The groups are really doing well. They've been really robust. I run a couple of groups every month as well. The newly diagnosed group had a nice group of people this week. Our transplant pathway group, we have had people start in April in the group and go all the way through the listing, the transplant, and the recovery now. And they stay on, and then they help the next people that are going down the path. It has been amazing. We just had another transplant of one of our, she joined her first meeting last month, got transplanted just a few days ago, and is doing well over in England. So please join the groups. They're wonderful. They're inspiring. They're fun. And I'm really happy the way the program's developed. I do my Tales from the Heart twice a month. You can listen to us wherever you get your podcasts. We do one with Marty Marin and one with Dr. Lever. And next year, we're going to have all new programming, all new artwork. It's season 2, and we are going to have monthly visitors from Centers of Excellence. We're going to have deeper discussion groups. We're going to have a bunch of wonderful things going on. So join us every Friday at 11 o'clock. We'll broadcast live on Facebook, record, and then upload to wherever you get your podcasts. As a reminder, the Invitae genetic testing panel called Detect is still available for free for any family living with HCM and wants to know your genetic status. You can find the information on this. If you just go to the website and type in genetics, it'll bring you right to it, and you follow the link, and any member of your family is eligible to get free genetic testing. Please remember, we're going to learn about genetics tonight, where you should start and where it should lead to. So you'll learn about that in just a few minutes. Before I say my thank you, I do have a special announcement for a really special program we're running next week. Julie, if you would be kind enough to put the date and time, because it slipped my mind, of the African-American HCM experience discussion. We are going to do a webinar-based approach. Actually, it's going to be live Zoom, sorry. And we're going to be live on Facebook for that event. And we're going to have a dialogue with members of the African-American community who are affected by HCM. And we're going to start a tough conversation. And that conversation is, why are most HCM programs predominantly Caucasian patients when HCM affects 1 in 250, regardless of our ethnic background? So we need to do more to find those members of the African-American and Black community who have HCM. And we then also need to reach out to our Latino HCM patients and our Asian. We don't have enough mix in the United States in our HCM populations that represents true HCM. So we have to do a little bit of work to go find them. Clinically, HCMA has to find them, the Centers of Excellence have to find them, and we have to make sure that those families are getting the care that they need as well. So with that, I say thank you to our partners tonight. at Washington University in St. Louis, our staff, our board, and of course, as always, I wouldn't be here if it were not for my donor, Brandy. So thank you to Brandy. She's doing a good job. And I'm going to hand it back on over to our team at Barnes, and everybody can come back on camera with me. And next up, we have Sharon, who's going to talk to us about genetics and families with HCM.
Great. So let me just share my screen. Just give me a second here.
You're good to go. And I got to tell everybody how impressed I am with that artwork up front. That's one big old HCM heart.
So nice to meet everyone virtually. And I am Sharon Cresci. I'm going to start off by discussing hypertrophic cardiomyopathy, the diagnosis, and the genetics. At our Center of Excellence, as Dr. Bach said, we offer a comprehensive integrated approach that includes all of the services listed on this slide. And my areas of expertise, as he's mentioned, are in imaging and in genetics, where my role is to counsel patients and their families about HCM and to discuss genetic testing. And so I'm going to speak about both of those aspects tonight briefly. And also talk a little bit, just to mention a observational registry that I direct, and I'll discuss a little bit about that at the very end of this talk. So before I start discussing imaging and genetics, I would like to say a few words about our Hypertrophic Cardiomyopathy Center of Excellence and why I think it's special. I recently had the opportunity to participate in a study that explored the experiences of patients and their response to the diagnosis and treatment of HCM and the impact that that had on their quality of life. And with this perspective, I wanted to highlight several aspects of our center that I think are extremely valued by our patients. We believe that spending a lot of time listening to our patients' concerns and answering their questions is critically important and improves the care of our patients. We greatly value shared decision-making and take an integrated interdisciplinary approach to treatment options. We also collaborate very well with referring physicians so that our patients never feel like they are in the middle of their referring physician and and our group. And some of the patients in that paper, when we were exploring their perspectives, they identified that as being a problem in their care where they felt like they were in the middle. And so we absolutely never do that. We try to be really excellent collaborators with referring physicians. As you are all aware, HCM is a disease state in which morphologic expression is confined solely to the heart. It is characterized predominantly by left ventricular hypertrophy or thickening in the absence of another cardiac, systemic, or metabolic disease capable of producing that magnitude of hypertrophy. It has been estimated that 6 out of 7 individuals with HCM have not been identified and are unaware of their disease based on comparisons of claims databases and population screening studies. The prevalence of HCM is reported to be, as Lisa said, between 1 in 500 and 1 in 200. And so, given that the current population of the United States is 332,796,770 individuals, that means that there are between 665,000 and 1.6 million individuals with hypertrophic cardiomyopathy in the United States. And if you do the math, that means that between 570,000 and 1.4 million individuals do not know that they have HCM. And so obviously this is a huge problem that people are not aware that they have this disorder. The underdiagnosis and the misdiagnosis of HCM is supported by patient experiences. And in the paper that I just mentioned, the accuracy and time to diagnosis was explored. Some of the patients described that they had HCM accurately diagnosed in a very short time frame, within a week or so. But some patients reported repeated misdiagnoses occurring over a time frame as long as 26 years. Obviously, we want to address that problem. The diagnosis of HCM is primarily made with echocardiography. And this is a view of one of our ultrasonographers doing an echocardiogram on one of our patients, who gave permission for that, by the way. And at our center, we are very proud of the fact that the echocardiograms performed on the patients who come through our center are performed by 3 dedicated, experienced ultrasonographers who specialize in HCM. We believe that this is critically important for highly reproducible studies, especially when we're measuring the wall thickness and the LV outflow tract gradient and following these parameters over many years to see if they are changing or staying the same. Our ultrasonographers are shown here, Kara, Crystal, and Rachel. And those of you who come to our center know that these ultrasonographers are extremely fantastic, extremely personable. I think you would all agree that they are just fantastic. This is a list of the initial examinations that we perform with a full resting echocardiogram, where we're looking for the HCM phenotype, the maximal wall thickness, a full assessment for imaging, the risk factors of for looking for those imaging risk factors of sudden cardiac death, such as left ventricular aneurysms. And then we also perform stress echocardiogram for evaluation of the exercise capacity, symptoms, and LV outflow tract gradient. And we very much follow the guidelines and make an effort to be on the cutting edge of knowing what should be done for our patients. We also carefully look for other echocardiographic features that are consistent with hypertrophic cardiomyopathy and may help with the diagnosis, even though they're not needed for the diagnosis, such as elongated mitral valve leaflets, anomalous papillary muscle insertion, and myocardial crypts. We perform strain imaging on every patient, and this is an example of what's called a bullseye plot of longitudinal strain. So longitudinal strain imaging is a method in echocardiography for measuring regional or global deformation of the myocardium, and values more negative than -15 are considered normal. This is a normal patient here shown. And as you can see, each of the segments of the myocardium has a value that's more negative than -15. And the global strain is also more negative than -15. It's -21.6% here. The images on the right are from patients with hypertrophic cardiomyopathy. And as you can see, what the arrow is pointing towards, these patients have markedly abnormal strain in their basal anteroseptal segments or the basal anteroseptal and basal septal segments. And we pay very careful attention to this because this is suggestive in our patients that they may have early disease. We also pay attention to the shape of the left ventricle, as this may also be useful. And as seen on these images from the patients with HCM on the right, the shape of the left ventricle is often crescent shaped, shown in the 4 images on the right side of the screen, compared to the normal on the left. We recognize that accurately measuring the wall thickness is critically important to the diagnosis of HCM. As you see here, the diagnostic criteria, as per the most recent guidelines, give the cutoffs with a cutoff of greater than or equal to 15 millimeters, and a borderline measurement is considered to be 13 to 14 millimeters in adults. But we also recognize that the left ventricular hypertrophy or thickening may be limited and focal and may be confined to only 1 or 2 left ventricular segments. And so for this reason, we believe that echocardiographic image enhancement is critically important to accurately measure the left ventricular wall thickness in many of our patients. And we pay very careful attention to that at our center. So this is an example of where it was important to use image enhancement. This is an image from a patient who was referred to our center. And, on first glance, the image appears relatively good. The endocardial borders appear to be relatively well visualized, and the left ventricular wall thickness might be interpreted as normal. However, this is the same patient with image enhancement. And as you can see, the arrow is pointing to where this patient has significant hypertrophy, which is involving the apex. And this would be consistent with a diagnosis of apical variant HCM. Image enhancement also helps us identify apical aneurysms, which is an imaging risk marker of sudden cardiac death. And once we visualize this, it allows us to provide this important information to our electrophysiology colleagues. And I imagine Dr. Gleva will allude to apical aneurysms in her talk. So this is another example of a patient that we might see. A patient referred to us for a screening echocardiogram. She is a 35-year-old woman. She is asymptomatic. Her brother was recently diagnosed with hypertrophic cardiomyopathy, but she has no other known family members with the diagnosis. However, she underwent genetic testing and it was positive for a familial pathogenic variant. And this is her screening echocardiogram shown here, the non-image enhanced view on the left and the image enhanced image on the right. And here's a still frame showing the measurements that were made on the image enhanced view. And as you can see from this, the septal thickness was measured to be 1.3 centimeters or 13 millimeters, and the posterior wall was measured to be 11 millimeters. So as I showed before, the guidelines state that a wall thickness of 13 millimeters is considered borderline in some instances, but it is diagnostic when it's present in a family member of a patient with HCM or in conjunction with a positive genetic test. And this patient had both. They were a family member and they also had a positive genetic test. So this patient therefore has the diagnosis of HCM. And just for completeness, I'm showing the global strain, longitudinal strain here, and you can see there are some abnormalities in the anteroseptal, the basal anteroseptal segment as well. So all of this is, just examples to show you how we really try to comprehensively evaluate anyone who is referred to our center. I would like to discuss an example of some important work that we've done with imaging before I move on to the genetics. And we've done this, to help improve the treatments of patients with HCM who may need surgery. And these results were recently published in Circ CV Imaging. And as you can see, there are several of our center members here that were part of this effort. And this shows the reasoning why we went down this pathway. So despite maximal medical therapy, many patients with obstructive HCM require septal reduction procedures to relieve their symptoms. I'm sure you're all aware of that. We have found that older patients with obstructive HCM are increasingly referred for septal reduction therapy. And there's an interesting other fact that we've noticed, that the prevalence of structurally abnormal mitral valve architecture and resultant intrinsic mitral valve regurgitation, or MR, also increases with age. And this form of intrinsic mitral regurgitation is different from and is not the same mitral regurgitation as we would think of as being HCM related mitral regurgitation. And importantly, the treatment of the mitral regurgitation actually depends on the etiology of it. So the treatment for intrinsic mitral regurgitation is a mitral valve repair or replacement. However, the treatment for the SAM-related mitral regurgitation is septal reduction therapy alone without a mitral valve repair or replacement. And so at our center, we developed a specialized HCM protocol, Trans-Esophageal Echo, that is designed to assess the patients with significant mitral regurgitation when we are evaluating them for septal reduction therapy. We take advantage of the differential effects of phenylephrine on intrinsic mitral valve regurgitation versus mitral regurgitation related to hypertrophic cardiomyopathy. And in patients with intrinsic mitral regurgitation, the mitral regurgitation becomes more severe when afterload is increased with the administration of phenylephrine. But in contrast, based on the physiology of HCM, increasing the afterload with phenylephrine will decrease the degree of LV outflow tract obstruction and improve the MR if the MR is due solely related to the hypertrophic cardiomyopathy. And so this is an example of one of the results that we got and that we published. This is a still frame of a transesophageal echo. We could see here, this is the left atrium, the left ventricle, the left ventricular outflow tract. And then all of this here is the mitral regurgitation, which is shown by the yellow and bright blue pixels. And there's obviously a lot of that color on the frame in the left, and this would be considered significant mitral regurgitation. And then you can see on the right-hand panel, once we increase the blood pressure and increase the afterload by giving intravenous phenylephrine, the mitral regurgitation becomes much less, and it's actually almost gone. Excuse me. And this is seen in real-time imaging as well. I think you can actually see it a little bit easier, that we've almost completely improved the mitral regurgitation. And so our studies showed that this patient would not need mitral valve surgery along with their surgical myectomy, but would just need a surgical myectomy. And we felt that this method is very important clinically, as it can prevent unnecessary mitral valve surgery and also result in shorter operation times. That's just an example of the things that we are trying to do to improve the care of our patients here at our center. For the next part of the talk, I would just like to discuss a few points about HCM and genetics. And this is our description of our cardiovascular genetics clinic here. As I said, our center is dedicated to comprehensive care of patients and their families with HCM. And because this is an inherited disorder, we provide screening and counseling to all of our first-degree family members. We know that hypertrophic cardiomyopathy is caused by more than 1,500 causative variants in genes that encode the cardiac contractile unit, or the sarcomere. However, having that causative variant is not enough. Although HCM is a genetic disorder that's inherited in an autosomal dominant pattern, meaning that a parent with a pathogenic variant has a 50% chance of passing on this variant to their child. But we also know that HCM has variable penetrance and variable expression, and I'm sure that you may have heard these words before. So variable or incomplete penetrance refers to the fact that if you have two individuals in a family who inherit the same pathogenic variant, one of them might develop the left ventricular hypertrophy or thickening, and one of them might never develop any clinical manifestation of the disease. Variable expression refers to the fact that in individuals with the same pathogenic variant, even in the same family, there can be different distributions and severity of the left ventricular hypertrophy and different onset or progression of the disease. So this family tree or pedigree on the right side of the slide illustrates these points. And I love this slide because it shows it so clearly. So in this family, the father, who's labeled A, carries a single pathogenic variant. And you can see in the still frame from his cardiac MRI, the distribution of his LVH is mainly in the antroseptum, which is labeled with an asterisk. 3 of his children inherit the pathogenic variant, and they're labeled B, C, and D. His first son has more extensive hypertrophy, but it's still in the antroseptum. His first daughter has a more apical distribution, and his second daughter has no cardiac abnormality on MRI. In other words, she does not have the HCM phenotype at all. and she may never develop the disease throughout her lifetime. So what does this mean to families with a first-degree relative who has been diagnosed with HCM? Well, it means that if your relative was diagnosed with HCM at age 35, you may develop HCM at a much younger age or a much older age or not at all. If your relative with HCM has a lot of hypertrophy, you may have a little hypertrophy or a lot of hypertrophy or none. If your relative with HCM has specific symptoms, you may have the same or different or no symptoms. So it's very difficult for us to predict based on your family history what will happen with you. And to screen for family members, the choice really is either clinical screening or genetic testing. And these choices are obviously not mutually exclusive. But at our center, we can have this discussion and we can provide guidance as to the timing and the ways of screening and make sure that we're following the guidelines to perform the screening at the proper intervals so that we don't miss a diagnosis of HCM in any first-degree family member. As I said before, we really do believe that similar to other decisions in HCM, shared decision-making should be used when making decisions about family screening and decisions about whether or not to perform genetic testing or clinical screening or the timing, when to consider each of those. Our center offers a thorough, comprehensive approach to genetic testing and counseling with all of the components shown in the blue boxes. And I want to emphasize that in the guidelines, they do stress that every single component of this should be offered if you're considering genetic testing, that you really need to have someone who is familiar with all of these aspects, that can provide detailed pre-test counseling, that can discuss what your test means once you get the result, and can help assist with family communication and predictive testing. When patients come to see me and families come to see me, we do discuss the main utility of genetic testing, and I've listed the 4 main reasons to do genetic testing here. Sometimes it can help make the diagnosis of hypertrophic cardiomyopathy, especially if the phenotype is ambiguous. So a positive genetic test in that situation would help confirm the diagnosis. It is also important to realize that we can identify phenocopies or a disease that looks like hypertrophic cardiomyopathy, but actually is not. And I'll get into why that's important in just 1 minute. It's also important, as I discussed, to risk stratify family members and to offer reproductive counseling. So phenocopy genes are listed here for your reference. And the reason why it's important is that some of these, to identify them, is that some of these disorders have specific treatments that would be indicated and are different from the treatment of hypertrophic cardiomyopathy. So all of our genetic tests do look for phenocopies, and it's a very important reason to do a genetic test. We also discuss the yield of genetic testing when I see patients, and discuss that you in general have about a 50% chance of having a sarcomeric pathogenic or likely pathogenic variant identified. But we also discuss what it means if your test comes back negative, so a pathogenic variant is not identified, and what it means if you have a variant of unknown significance. And then we also discuss different clinical markers and parameters that might increase the yield of your particular genetic test. We also discuss, as I said, the potential results of the test and what it means if a VUS, a variant of uncertain significance, is identified. It's currently not felt to be a clinically actionable result, but the guidelines do discuss that a VUS can be investigated further at either a clinical or research level to further clarify the variant pathogenicity. And I want to stress that we are happy to provide guidance about all genetic test results that is specific to your family. And that I think is the most important thing is that we discuss all of these, everything about genetic testing and make it specific to you and your family. We answer your specific questions and concerns, and we provide guidance about your specific result as it relates to your family. And I can't emphasize enough how important I think that is for each of our individual patients. So our ultimate goal is to define optimal therapy based on a comprehensive evaluation that includes all clinical information for every individual with HCM. In other words, we ultimately would like to use precision medicine approaches for every individual with HCM. And toward that goal, we have developed a voluntary observational registry, which many of our patients, almost all of our patients, participate in. It does not determine their care or their treatment. It doesn't doesn't change the way we treat them, but we follow them observationally to see what happens and if we can identify specific subgroups of people that might do better with one treatment versus another. And we offer this participation in this registry to all of the patients who come through our Center of Excellence. So in summary, I hope I've given you an idea of what our center offers from an imaging and genetics perspective. Advanced imaging techniques and a focus on comprehensive care, including careful attention to family history and genetics, are important to the care of every patient with HCM and offered routinely at our HCM Center of Excellence. And with that, thank you.
Thank you very much, Sharon. That was great. Some of those explanations were I don't know what's happening out my window right now. There's motorcycles in Denville, New Jersey this evening who are very excited about this presentation. They just were all revved up. Come on, do I get a laugh for that one? Sorry about that. I didn't expect that to happen. Okay, so those explanations were great. I'm going to steal some of your analogies, and thank you so much for that great talk. Next up, we have the Girl Squad quite well represented this evening in our physician panel. So I guess Marye Gleva is up next to talk to us about electrophysiology, a shocking topic. Okay, come on, guys. I got to get a laugh at some of my jokes tonight.
Well, I thought that was really funny, and I hopefully can shed some light on that. So I'm Mary. I'm one of the EP members of the HCM Center of Excellence, and I want to say a particular thank you to Lisa and Amy and Julie for all their help in doing this and being the leadership in the country for a wonderful patient care and provider care organization. And a huge shout out to Rich, to his leadership for our Center of Excellence. It's exactly what Sharon said, that we try to be an integrative, kind of collaborative approach amongst our own selves, as well as patients, families, and referring providers. So what I want to address today is this concept of sudden death prevention. Talk about what does it actually mean, and what do I as a patient need to know when I'm going to see someone about this issue. And I'm going to say up front that this can be a somewhat uncomfortable conversation to have, especially when you haven't met the clinician or provider and we're talking about a sudden arrhythmic event that can be quite emotional, tragic, and what I hope to talk to you about is what we know that we can do about it. So hopefully everyone can see my screen, and let's see.
It looks perfect.
Okay, but let's find the next slide thing. That one. How am I going to do that one?
Are you? Let me come back into the room with
up
you.
and down, and that's just doing that. So
That's odd.
Is
are
odd.
you in present mode?
I should be. So you know what I'm going to do is stop the share for a minute and exit out and just make sure.
Try it again.
Let's see if I am not in. Let's try share again. And see, this is going to go to my next slide, and I'm a little stuck.
Oh boy. You could attempt, I'm trying to troubleshoot with you in all my PowerPoint glitches of my life.
Page down. There we go.
There you
We've
go.
got it. I am using a different system here, but I appreciate everyone's help. So these are my disclosures. You will see that many of these are device companies. I do a lot of clinical trial work looking at electrograms, and so that's what my disclosures are. So tonight I want to talk about three main concepts. What is sudden cardiac arrest and sudden cardiac death? Why is it important in HCM, and what do we do to prevent it? So kind of three big bullet points. So what is sudden cardiac arrest and sudden cardiac death? So the AHA defines these things, and of course we have to talk about the electrocardiogram, and which we'll get to. But sudden cardiac arrest is the sudden cessation of cardiac activity, such that a person becomes unresponsive. Can be a rhythm problem, can be a blood pressure problem, can be other vascular problem, but there's no cardiac activity and the person will not speak to you, breathe, or respond. Sudden cardiac death is unexpected death that occurs within an hour of symptoms or within 24 hours of being well. And for decades in EP and arrhythmia trials, we've presumed that this is due to an arrhythmia, maybe changing a little bit now. But in general, we think that this is some life-threatening arrhythmia. And of course, sudden cardiac death occurs when our efforts to resuscitate sudden cardiac arrest are unsuccessful. So really the goal is to deal with sudden cardiac arrest so it does not become sudden cardiac death. And so how do we know these things? Well, the guideline statements that Sharon referred to in the arrhythmia world exist and define these things for these concepts. But starting with the electrocardiogram is where it all begins and is super important. So I'm actually going to go over the electrocardiogram so that our participants will kind of know when they come into a clinician, what are we talking about and how do we know what we know? So the electrocardiogram is an electrical picture of the heart's intrinsic electrical activity from the surface of the chest. And we put all those stickers on and hook up the little clips, and this is what we get out of it. And I hope you can see my pointer, but each of those stickers gives us one of these lead tracings. And if you just look at this, you can see that there's a repeating pattern. For the engineers out there, this is voltage and this is time. So it's really a tracing of voltage over time. But you can see there's a repeating pattern, this little bump, big sharp guy, and then this middle place guy. And so what we know from the heartbeat is this is the atrial activity. And the atrial activity starts in the upper right-hand corner of the heart, the northwest corner of the heart. And I'm actually coming to you live from Seattle. So the northwest is kind of where the heartbeat starts in my world. And then this electrical signal here is the ventricular signal. And then the ventricle has to reset itself. And that's what this guy is. So this is a repeating pattern that has been noted for almost 100 years on the electrocardiogram. And each heartbeat has this pattern. People's complexes will look different, but we all should have a P wave, a QRS, and a T wave. So that's what normal is. Okay, where are my abnormal ones? Well, they're gone. Well, at any rate, so how do we know what the ECG means? Well, it's a fundamental test in cardiology, and it's pattern recognition. And of course, it's based on nearly 100 years of clinical experience. And so we know from William Einthoven way back in 1924, he got the Nobel Prize in Medicine for discovering the electrocardiogram. So this is the Nobel Museum in Stockholm. This is the outdoors. This is the indoor gallery where they display all the Nobel Prize winners, and the medicine folks are in there. And this is a picture of William Einthoven. And I thought it was really interesting that it's almost been 100 years where we've learned about the electrocardiogram, but it's super important in thinking about the heartbeat. So this is the electrocardiogram in sudden cardiac arrest or ventricular fibrillation. And if you take a look at these same stickers on the heart, you can see that that pattern of a little bump, a big spiky bump, and a middle-sized bump are no longer here. This is just either it's up or it's down. It's some disordered electrical signal that does not generate a heartbeat. And we call this ventricular fibrillation. And this is not a good rhythm, and it needs an electric shock to reset it, or sudden cardiac death can ensue. But you can see that this pattern is disorganized, irregular. We can sit here and argue this is up, this is down, this is down, this is up. It really doesn't matter because there's no identifiable heartbeat in any of these leads. So what's ventricular tachycardia? Well, here's an example of what that is. And you can see that there is a repetitive pattern of something that kind of looks like those ventricular beats, but we really don't see great T waves and P waves. But there is a pattern here of a wide heartbeat. So clearly this doesn't look like the first ECG I showed you. It doesn't look like the second ECG that I showed you, but this is another rhythm that can occur that can result in sudden cardiac arrest and sometimes in sudden cardiac death. But this is abnormal as well. And so these are the things that we want to prevent from happening and causing adverse outcomes if we can. So why does HCM have this? And so if you think about the heart has muscle, it has valves, it has arteries, veins, an electrical system, and those all things need to function together. And on this panel A here, this is what a normal piece of heart muscle looks like under the microscope, with the heart muscle fibers running this way and different substructural functions there. And if you look at patients with HCM, then the muscle is abnormal. These proteins and from products of the genes that Sharon talked about so eloquently is disorganized and in disarray. And if you do different stains on the tissue, you'll see that there is fibrosis. There are small vessel changes, and this dye shows kind of the scarring or the changes outside the muscle. And the key concept is that abnormal muscle has abnormal electrical properties. And in our world, we call this refractoriness, dispersion, which means kind of it's disorganized. But because of this electrical problem, it gets manifest as those ventricular arrhythmias on the electrocardiograms that I showed you. So abnormal muscle can have abnormal electrical properties, which can show up at unpredictable times as rhythm problems, which can be life-altering. Okay, so how do we know that this actually happens in patients with HCM? Well, over 20 years ago, in nearly 800 patients with a bunch of centers in the United States and in Italy, so we're really glad they're coming on board, the HCMA Association, they looked at what happened to people. So they polled the doctors and said, what happens to your patients who have HCM and what happens based on their age? And so this y-axis is mortality. This is age at initial evaluation. And this is mechanism of how people passed away. And so you can see in the very young age groups, unfortunately, this black bar representing sudden death or sudden arrhythmic death was the predominant mode of death until you hit your mid-30s. And then other muscle problems manifest. In the hatched bars, it's heart failure. So then we start seeing a heart failure signal as well as some arrhythmic signal. And then when we get older, it turns out that the rhythm signal gets higher, the heart failure is there, but then we start seeing a stroke signal. And so the stroke issues become prominent as patients get older. And that is thought to be associated with atrial arrhythmias and risk of stroke, which is not really what we're talking about in this discussion this evening, but it goes to show you how things change as patients go through different decades in time in their life, which means continued follow-up and comprehensive follow-up remains very, very important. But how we learned about what happens in patients with HCM and what we need to work on comes from some of the seminal work that was done 20 years ago. So annual rates of death, 1.4% were sudden death, heart failure was half of that, stroke was the lesser percentage. So what happens now in 2020? Well, the guidelines that Sharon talked about were recently released by the American Heart Association and have fundamentally changed, I think, how we evaluate, treat, and educate our HCM patients. And now we know that patients should be screened at their initial visit for these rhythm risks, and then the screening and assessment needs to be repeated every 1 to 2 years, or if there are changes in symptoms. So it's not a one and done. It's a let's start and let's continue the conversation. So Sharon alluded to some of these risk factors, and these are new and evolved since the earlier set. Well, if someone's had a history of a cardiac arrest, in the arrhythmia world, we know that that person is at risk potentially of a future event. So that's a high important risk factor. So we were always in electrophysiology going to ask someone, have you ever required CPR? Have the paramedics had to come to your house to shock your heart? What about your family? Does your family have a history of that? And these can be very unsettling discussions because we're asking patients who we are just meeting to bring up a concept or a discussion point of something that is tragic, emotional, and can be hard to handle. So, you know, I like to apologize to people up front that we're going to talk about uncomfortable subjects, but it's necessary to do, and I'll explain when I see folks in clinic why we have to talk about it. So the next risk factor that's important is the thickness of the ventricle. And we've talked about massive thickness, which usually means 30 millimeters or 3 centimeters. And those echocardiograms that Sharon showed and the MRI showing where the heart muscle can be thick is crucially important to us in electrophysiology to think about how this impacts decisions that we make with our patients. Unexplained fainting. People can faint for multiple different reasons. You get the flu, you throw up, you have diarrhea, you lose blood volume, you can faint. But there's unexplained fainting, which means there is no good reason for why someone passed out. Unexpected, unexplained fainting around the time of exertion. These are warning signs for fainting and can indicate the presence of an arrhythmia that may have stopped on its own. So the passing out is an important thing for us to elicit when discussing risk factors and history with patients. So also those episodes of ventricular tachycardia don't have to hang around all the time. They can come in little bursts of things. So we will actually frequently get patients to wear a monitor for 30 days or 14 days to see if they have rapid episodes of ventricular tachycardia that start and stop on their own. Because the faster they are, the more frequent they are, those are risk factors of having a potential subsequent event. The MRI. The MRI has now become critically important in assessing our patients who have HCM. And if you come see me in clinic, we talk about the echo. If the MRI hasn't been done, we talk about getting an MRI to look at the scar burden. And LGE means late gadolinium enhancement. Gadolinium is the imaging agent that helps bring out scar. And if that is quantified at greater than 15%, then we know that's a risk factor for having a ventricular arrhythmia. And the way to really think about this conceptually is the LGE percentage being higher is more abnormal. And we've talked about how abnormal muscle and scarring can lead to abnormal electrical system. So it makes intuitive sense why the two coexist. Now, the ejection fraction is a very common measure of lots of what we do in cardiology. And in general, an ejection fraction that is greater than 50% is considered normal. But we know specifically in HCM that patients frequently have a much higher ejection fraction than 50%. And when that number gets below 50%, that is a risk factor for having a ventricular arrhythmia. So it's the specificity, and Sharon mentioned kind of the tailoring of these risk factors to the individual becomes very important in sorting out risk factors. And then the apical aneurysm, which we saw a picture of. So an aneurysm is an area in the heart that moves abnormally. The left ventricular apical aneurysm is an area in the tip of the heart that moves abnormally. And if it moves abnormally, it means the muscle's abnormal. And if the muscle's abnormal, then the electrical system can be abnormal. And we know in patients who have this finding that they can have ventricular arrhythmias that come from this area. So this is another one of these specific patient markers that go into the current risk factors that we look for and evaluate to determine if someone has an increased risk of having a ventricular arrhythmia. So, and the bottom line on this is that if you have just one of these risk factors, it is enough to go on to consider an implantable defibrillator as prevention. So my next topic here is, how do we know that the defibrillators are useful? Well, again, 20 years ago, Dr. Marin and colleagues, Dr. Link, Dr. Epstein, Dr. Barty, Dr. Estes, and Paolo Spirito from Italy put together their experience in their HCM patients who got a defibrillator and followed them over 10 years to see what happened to them. So the curve on the bottom left shows a dark line for what we call secondary prevention and a dashed line for primary prevention. What secondary prevention means is that these are patients who had a prior cardiac arrest. So they had ventricular tachycardia or ventricular fibrillation, were successfully resuscitated, then underwent ICD implant, and then over time, their risk of having another appropriate defibrillator discharge got up to nearly 70% out at 10 years. So we know that this is a high-risk group. If you've had a prior cardiac arrest, you are at risk for a subsequent one. Anyone is. The primary prevention patients are those where the clinician thought the patient had increased risk, but fortunately had not had a prior cardiac arrest. It's patients with non-sustained VT, fainting, or that family history that we talked about. These patients went ahead and had defibrillators implanted, and over almost 10 years of follow-up, we saw that maybe 1 in 5 of them could have had an appropriate defibrillator shock to terminate one of those arrhythmias. So this was not a randomized trial. This was observational registry data, but gave us the best clue that we have that defibrillators help patients survive these arrhythmic events. So it was 128 patients. That's considered a small trial nowadays, but this was monumentally important. And this is likely why it became a publication in the New England Journal of Medicine. Now it's 20 years old, nearly 21 years, 22 years old, but it's still relevant in how it impacts our decision-making. Okay, so what actually is a defibrillator? It's a device that can shock the heart for a rapid abnormal rhythm. Some of those devices are pacemakers, but in general, pacemakers are designed to treat slow heartbeats, and a defibrillator is designed to treat fast heartbeats. The defibrillator in general is reasonable to consider in any HCM patient who has more than one or more of those established risk factors. And it is critically important, like Sharon said, that a shared decision-making discussion occurs when deciding about having an ICD. It's not just about having an implant procedure. It's about an implant procedure requiring follow-up, living with an implanted metal device in your chest, and the possibilities of what happens 10 or 20 years down the road. So I liken it to telling folks that, look, this is a journey and we're going to go down this road together, and there may be some detours in the road that we'll have to talk about and that we'll have to address, but we're going to do this together because it's considered lifelong therapy, at least at the current state of information. So the types of defibrillators are transvenous and then subcutaneous. So we're going to talk about this. Transvenous means it goes through a vein. And this is the most common defibrillator. This has been around for 40 or 50 years. In general, these defibrillators have wires that have to go through the vein into the heart. And that's what these black lines are. The blue thing here is the vein. Here's the heart chamber, and here's the wires in the vein. So usually there's one if it's 2 wires in the atrium and one's in the ventricle. And the device is under the skin on top of the muscle. Yes, it's subcutaneous, but the system that delivers the energy to the heart is through the vein. And this just shows what a pacemaker is. And the pacemaker is very similar in that it has leads through a vein that goes into the heart. The device is generally smaller, but this is designed only for slow heartbeats. Most transvenous defibrillators can pace the heart and usually require only one incision. How they pace the heart depends on the number of leads. But this, I think, is a good example of a standard defibrillator. Now, because standard defibrillators have issues, which we will talk about, there's been advances in technologies to avoid going into the vein and inside the heart. This is called the subcutaneous defibrillator. And in this device, everything is under the skin. The generator here is on the side of the rib cage. The wire goes along the rib cage. The wire goes under the skin along the sternum. So this is another way of defibrillating the heart without going into the vein or into the actual chambers of the heart. There are no wires in the veins of the heart, and this device does not pace, so it does not treat slow heartbeats. It's located not up here under the clavicle, but an incision here by this yellow line in the chest area, and another incision here kind of at the base of the sternal bone. And so this is a 2-incision device and may well be appropriate for patients with HCM, but there are strategies that have to be evaluated to determine if the device will actually work based on each individual's heartbeat. Okay, so why do we develop this? Well, this was developed because we know that transvenous defibrillators have problems. Lead problems, they're always the #1 issue in any large series of defibrillators. But you go into a vein, you can get bleeding. Infections can happen. Patients, unfortunately, can be shocked for rhythms that are not VT or not VF. Every 8 years or so, you need another procedure to replace that battery, the unit that's under the skin. There's risks of component recalls. And if you were to see me in clinic in 2021, I tell patients today that almost every device company has some form of a recall. It does not mean that every device is recalled, but there are components, chips, leads, pieces of the battery, the header that have issues that have been identified. So dealing with this is a lifelong commitment and strategy. These devices have to be followed up because things can happen. But there are rare risks of heart attack, stroke, death around the time of the procedure. Fortunately, they are very low, around 1 in 1,000. I wish they were 0, but they're not 0. And these risks now exist over a person's lifetime. And like I mentioned earlier, it's not simply one and done. Okay, so the Heart Rhythm Society, our major academic society, emphasizes, as Sharon has said, the importance of shared decision-making, and it has to be part of heart rhythm care. The guidelines say that we clinicians need to adopt a shared decision-making approach to discuss treatment decisions based not only on best available evidence, but the patient's health goals, preferences, and values. And that is critical and central to this discussion. And it must occur prior to device implantation. And we, the clinicians, must document this. And certainly there are different tools that are under evaluation for doing this process. We saw this slide earlier from Sharon, and similar to these other decisions, we do the same thing when it comes to that red box in the bottom corner about defibrillators. One of these tools comes from our colleagues at the University of Colorado, and they call it the Icd Decision Tool. It's on this website. They not only talk about ICDs, but they talk about other decision things as well for patients. And the nice thing about this is it's provided both in English and in Spanish. Now, this is designed, however, for the vast majority of patients who are looking at getting an implantable defibrillator, and but these specific curves are not for HCM patients necessarily. but the information is very useful, and going through this process with the clinician is important in making sure that the decisions that are made with the patient's goals in mind. Okay, so kind of summing up as well, what else can I do? Well, I'm from Seattle. I come from training programs where the emphasis on knowing CPR, knowing how to use an AED, and for community members to know this is part of our nature. And I know that this has been an effort that Lisa has led nationally, which I think is fantastic. So we also encourage patients, family, friends, neighbors to do the same. So the Heart Association has training online for this at this Heart Saver Cpr Aed Training. There's an app which is called the Pulse Point Response. So if you are someone who is CPR AED trained and someone's having a cardiac arrest nearby, this app will alert you. This is not just in the United States where these things are important. This is a picture I took on the train from Stockholm to Copenhagen. And here is a picture of an AED. And I think this is Swedish, might be Danish, but these are available everywhere and it's wonderful. In France, they've talked about drones delivering defibrillators to patients in the community who have a cardiac arrest. There are ways to do this, but the person on the other end needs to know how to use it. So we encourage all our patients as part of being a good community member to learn CPR and learn how to use an AED. So in summary, the risk of sudden cardiac arrest is an important clinical discussion for all HCM patients. We have to do this with our patients on a regular basis. There are established risk factors which we've identified and which Sharon has discussed and shown pictures of. And if any one factor is present, then the discussion of should I get an ICD is very reasonable to undertake. But the decision to have the defibrillator is very much individualized. And I've spent 20 years at WashU seeing patients who've had defibrillators who've saved their lives, and it's incredibly rewarding. But we've also seen patients who've had complications, and I wish the complications would be zero for these devices, but unfortunately it's not. Do we need better technology still? Absolutely, because the more I do this, the more I want less invasive, better designed devices for especially our young patients who are facing a lifetime of having a therapy that they will have to remember to have follow-up for and adjust. So I'm happy to stop here and answer questions when appropriate. Thank you for your attention.
Mary, thank you. That was awesome. I know that probably one of the most challenging questions I get, and I know you face this regularly, is that patient, and these people worry me, that don't have really any symptoms or are not feeling bad from their HCM yet are viewed to be at high risk of cardiac arrest. And getting the head around, I might die suddenly, but I don't feel bad.
Exactly.
Do you have any words of wisdom for people who find themselves in that classification?
Oh my goodness, this has been two situations which I've had recently with some young women, and as a mom and a parent, these are heartbreaking discussions to have, and I feel bad because the parents are crying and I have to talk about these horrible concepts. So what I tell them is, we will make the decision together. I really do use the words as this is a journey. I refer them to the website as well because there are patient support tools there. They may be able to talk with other folks who have faced this decision and get some more emotional support on a person level versus a doctor-patient level. I think it's critical to have that. And I think really importantly, they need to have this in an arena that is established, appropriate, and vetted. And that's the HCMA, no question. And I tell people this is individual. You have to sleep on it. You have to think about it. We have to play the B side of the record. And well, how am I going to feel if 10 years from now, there's a recall on my device. Am I going to be happy with this decision? How am I going to feel when I have to have yet another procedure? And so I tell people that I call it the intellectual emotional disconnect. We get it intellectually, why we need to do this, but emotionally, that emotional road for acceptance is very individual, and we can't rush it, we can't force it, but we have to do it together. And I feel quite strongly about it. And, you know, actually it's my HCM patients that are a big motivator to me and kind of other researchers that I work with to build a better device and give us better options. I want a non-invasive long-term option. It breaks my heart to talk with 18-year-old young girls about having a big chunk of metal in their chest. And personally, I think body image issues are important for these patients, which we are not great at addressing in my subspecialty, but I think we need to. So I think, you know, these patient interactions really motivate us to get better solutions. So that was my long-winded approach.
But it's a heartfelt approach as well. And, you know, just hearing the way you explain that, the empathy for what's going on the other side of the desk is obvious. And from the patient community, we appreciate that. When it's a cold conversation, it's kind of hard to take it. But if somebody can get vulnerable with you and say, I know this sucks, and really be there with you for that moment. You know, I had 5 devices throughout my life. Personally, Amy's had them as well. You know, we know what these decisions are, and that's where the discussion groups come in, peer-to-peer conversation. We actually have a standing every month ICD discussion group. I said, give me twice a month. So there's always an opportunity to talk about it, not too far away for patients. So thank you for that talk. We're gonna do a little pivot here, and I'm not quite sure which way we're going because we did make a change. It didn't make the graphic. So Richard, are we going back to you for the start of this and then going to Kunal, or are we going to go back the other way? Who's next?
We'll start with Kunal, and I will tag team.
Okay.
So I'm going to start. Let me share my screen, and hopefully this will get us. Okay, hold on.
There we go.
To, you know, so-called teeing up Dr. Kotkar as part of the discussion here, as we're, you know, talking about management of HCM. And you've already heard a bunch. Can everyone hear me, by the way?
We gotcha.
Great. Okay. And thanks everyone for hanging in there. You know, it's tough to hang in with a lot of presentations, but I hope you'll stick with me for the next few minutes as we do talk about some fundamentals and issues in management with an update on what the guidelines say. And you've heard that the guidelines were just recently published just about a year ago or so. So, you know, we'll talk a little bit about that update and lead into some further discussions about newer treatments. Now, there's no need for this slide because we've been talking about what hypertrophic cardiomyopathy is for the last hour or so. And you all know very well that there's a classic set of symptoms and issues that patients encounter when they have hypertrophic cardiomyopathy. Most commonly, patients may have symptoms related to what's termed heart failure, and that's more often shortness of breath and usually with exertion as the most common symptom. But there are individuals who have episodes of chest pain. Physicians call that angina or angina pectoris when they're talking about chest pain that occurs with exertion that's relieved by rest. And some individuals, as Dr. Gleva just mentioned, have an episode of passing out or what we call medically syncope. These are the 3 most common clinical syndromes that patients present with when they have hypertrophic cardiomyopathy. And then, as you also heard very well summarized on the previous presentation, there's a problem that some patients are at risk for sudden death. Now, when we're talking about treatment or management of hypertrophic cardiomyopathy, we want to focus on what the treatment goals really are. And they're not to focus on the measurements of the wall thickness or the measurements of the outflow tract obstruction. They're really focusing on relieving symptoms or preventing sudden death. Now, I'll leave the preventing sudden death part that you heard summarized so well by Mary And let's talk a little bit about symptom relief and how we get to understanding how we can relieve symptoms for someone who has hypertrophic cardiomyopathy. And that leads into what we would consider to be the routine evaluation for any patient who has suspected HCM. And these are not modern or newer approaches to an evaluation. The core evaluation includes what we would traditionally do for anyone where we're suspecting some form of heart problem, and that is taking a careful medical history. In this case with HCM, it's very important to take a thorough family history, to do a careful physical examination, to evaluate an electrocardiogram, and then at the focal point of the imaging that's required to establish a diagnosis of hypertrophic cardiomyopathy is the echocardiogram, as Dr. Cresci has already reviewed very well. And I want to say a couple of things that I think are germane to this question of why is it important to go to a center of excellence for hypertrophic cardiomyopathy? Well, you've already heard that hypertrophic cardiomyopathy is a highly variable illness from person to person, both from the standpoint of the morphology of the heart with the phenotype of hypertrophic cardiomyopathy, but also with the degree of symptoms that are expressed by that individual. And symptoms, in fact, may overlap with other conditions. So dyspnea on exertion or shortness of breath on exertion and chest discomfort, those are not only symptoms that come from hypertrophic cardiomyopathy, they're associated with many heart and lung disorders. And so sorting out exactly the cause of those symptoms is something that's quite important. And so therefore, the evaluation must be thorough, the imaging must be high quality, and the diagnosis must be accurate. And the diagnosis depends very importantly on the quality of that imaging and on the thoroughness of that evaluation. So we come to the specialized evaluation that would be more focused for individuals with suspected hypertrophic cardiomyopathy. And at the center of this is the stress echocardiogram. Now, Dr. Cresci mentioned this already, but we use the stress echocardiogram as a pivotal assessment for an individual to assess both those echocardiographic features of wall thickness and morphology of the heart, but in addition, what is the degree of outflow tract obstruction and how does it respond to walking on a treadmill? Individuals also need an ambulatory EKG monitoring to look for any of the presence of those risk factors that Dr. Gleva was mentioning, episodes of tachycardia that may be detected that a person may not even sense, can be detected by an ambulatory ECG monitor. It's commonly called a Holter monitor. And now more recently, with advances in imaging, cardiac MRI is also a very fundamental and important test for an individual as part of the specialized evaluation for hypertrophic cardiomyopathy. And then you've already heard from Dr. Cresci very well about the role of genetic testing. This slide is just to remind me to mention that these guidelines that were updated in 2020 are now published and helpful for the clinician, whether it be a physician in practice that you might meet in your community or a physician at a hypertrophic cardiomyopathy center. We do want to practice what we term these days evidence-based medicine, and these guidelines summarize a consensus of experts on what the true evidence-based medicine would imply for treatment of hypertrophic cardiomyopathy. I've reproduced on these slides on the left some of the algorithms that are published in those guidelines, just to focus on a few salient points. The first one is that whether or not there is significant left ventricular outflow tract obstruction is central to the evaluation of a patient with hypertrophic cardiomyopathy to determine appropriate treatments that may be beneficial for their symptoms. And that's where that stress echocardiogram comes in to evaluate both wall thickness, the exercise capacity, the peak exercise gradient, and the blood pressure response to the treadmill. So this is a very valuable and important test in the evaluation of anyone who's coming to understand how they can be treated for hypertrophic cardiomyopathy. And from some very important information, Marty Marin, you've heard that name earlier, has done a very careful analysis of the presence of outflow tract obstruction in individuals with hypertrophic cardiomyopathy. 30 years ago, it was believed that most patients were non-obstructive, but if one does appropriate provocative testing, and that's where walking on a treadmill is a physiologic way of evaluating the ability to provoke left ventricular outflow tract obstruction. You can appreciate from this study that a third of patients are provocable and a third of patients have severe resting obstruction. So the majority, or in the range of 70% of individuals, have significant left ventricular outflow tract obstruction either at rest or with some form of provocation. And that's important as we're considering what the treatments will be for an individual in these algorithms of treatment. And I want you to understand that if you come to, for instance, our center for evaluation, we work very hard to, for each patient, work out an individualized treatment plan based on their history and imaging studies. So this is, once again, not just based on the measurements of wall thickness or outflow obstruction, but more importantly on the amount of symptoms, the severity of those symptoms, the amount they're impacting one's lifestyle. And those are very important aspects of the evaluation that impact how treatment is determined. Now, what do the guidelines say about initiating treatments? I want to point out they don't start with invasive treatments such as myectomy and alcohol ablation that we'll talk about in a few moments. They talk about doing the right things with respect to medication treatments when they're indicated. And first of all, I want to emphasize that we should avoid or stop certain treatments that might actually make symptoms and the physiology of the heart worse. And those are termed vasodilators and diuretics. And unfortunately, because of that overlap between causes of shortness of breath and heart failure, many patients who come to the Center of Excellence here have already been treated with vasodilators and diuretics with good intentions to treat their symptoms, but unfortunately going down the wrong pathway with respect to treating hypertrophic cardiomyopathy. So the first line agent or agents that are recommended are what are called beta blockers. Examples of these treatments are two drugs. One of them is called metoprolol. Another one listed here is atenolol. These are medications designed to block the receptors for the adrenaline hormones in a person's circulation and on their heart. And it turns out that those are classic agents. They've been available for now probably more than 4 decades for the treatment of hypertrophic cardiomyopathy and many other heart conditions. It's important to realize that they are not a fixed dose medication, that individuals who have a need for beta blockers also have a need that they be titrated to a therapeutic dose where they're actually having an effect. And everyone's dose of metoprolol or atenolol might be different. And so it is something we work on together to get the dose correct so that it addresses the symptoms and is optimized, so to speak. Now, it's ironic to me, and Lisa will realize this, that since beta blockers have been used to treat hypertrophic cardiomyopathy for a few decades, that most of that has been based on simply anecdotal or observational data. There are some important studies, this one from 2012, which showed that the use of metoprolol actually reduces an outflow tract gradient for an individual who has outflow tract obstruction. But part of the irony here to me is that here we have a randomized trial in the year 2021 that was just presented. It's an abstract form only, so I don't have all the details for you, but it was done in Denmark, where patients with hypertrophic cardiomyopathy and significant obstruction were randomized between metoprolol and placebo and crossed over between the two types of treatments. And this study supported very well that metoprolol reduced the outflow tract gradient, improved the symptom class, what we call the New York Heart Association class for shortness of breath. It improved chest pain symptoms, and it improved the quality of life based on a questionnaire about quality of life. So metoprolol as a beta blocker has shown benefit, and now we have some randomized data to prove it, that beta blockers are beneficial for individuals in this kind of circumstance. Now, not everyone can take a beta blocker, and not everyone responds to a beta blocker. So for patients unable to take a beta blocker or with continued symptoms on a beta blocker, these guidelines recommend that we consider initiating or switching to what are called calcium channel blockers. And there are 2 members of that class, verapamil and diltiazem, that are recommended in these circumstances. This might take some, again, shared decision-making with a patient to determine if their symptoms are not responding to the beta blocker, how we'll make a transition to use these other agents. And I would say there are many patients in my own practice where a switch to, for instance, verapamil from a beta blocker seemed to have much more symptomatic benefit and avoided some of the potential side effects. And so this is a strategy that can be used to continue with medical treatments and where those medical treatments can be beneficial. Now, when patients don't respond to either of those two classes of agents, beta blockers or calcium channel blockers, and symptoms persist, there are a couple of different pathways that are considered for these individuals. Disopyramide is another agent that can have benefit for individuals, especially with obstructive hypertrophic cardiomyopathy. It is a little more difficult to use as a medication treatment. There are recommendations that it be started in the hospital, and so it does have to be started carefully. And so this is a choice in conjunction with shared decision with your physician that it might be recommended to initiate treatment with disopyramide. And there are some patients who have side effects where it really is not well tolerated. So it's a more difficult agent to use, but it does have benefit for many individuals and should always be a consideration, so to speak. But the guidelines list as a similar consideration septal reduction therapy for those individuals who might qualify for it. And so let me introduce this topic, which Dr. Kotkar and I will kind of tag team, which is now termed septal reduction therapy. If we consider who is it we're considering for this treatment, it's those individuals who have been either refractory or intolerant of drug treatments. And so people who have gone down that algorithm we just mentioned, but remain symptomatic, whose quality of life is impaired. And I would say we would generally reserve this for patients with significant symptoms impairing their lifestyle and quality of life. There are two considerations when one considers septal reduction therapy. Septal reduction therapy by surgery is called septal myectomy, and this is an illustration of that surgery. You can see the dotted line shows the bulge of the top or basal part of the septum that's obstructing the outflow of blood from the heart is surgically removed at the operation here, relieving the outflow tract obstruction and thereby relieving that high pressure in the left ventricle that can be contributing to these symptoms. And this is what might be called the gold standard treatment because it's been around since the 1960s, was developed at the NIH by a very innovative surgeon and has been improved over the years. So it turns out to be a low risk surgery with strong beneficial results. For individuals who might have either contraindications, meaning risk factors that indicate the risk for surgery, or might choose, they would prefer not to have major open heart surgery. The alternative treatment is alcohol septal ablation. That's a procedure that I do here at Barnes-Jewish Hospital as an alternative to surgery. And this illustration shows what we're doing is a catheter-based approach to inflate a balloon in the artery that provides blood flow to the part of the heart muscle where it is abnormally thickened and causing blockage. And by causing what might be called a controlled infarction or controlled damage with alcohol, the septum thins down during the healing process, which also helps relieve the outflow tract obstruction. I would emphasize, as you've already heard, that these treatment decisions are made in the context of shared decision-making. So I have, and Dr. Kotkar and Dr. Damiano have discussions with individuals who are interested in considering septal reduction therapy on what those risks and potential benefits of the procedure are. And we work together with patients to make what would be called a shared decision on whether they want to proceed with one or the other form of septal reduction therapy. And I showed you this illustration already. Here it is blown up a little bit, illustrating the balloon occluding the artery and the delivery of alcohol causing the septal ablation. This is all done in a cardiac catheterization laboratory with the guidance of the echocardiograph done by the experts from the echocardiography laboratory. Dr. Cresci comes into every procedure along with one of those sonographers that you heard about earlier. And so this is a procedure done with very careful guidance in order to achieve optimal results. And it should be performed by experienced interventional cardiologists at HCM centers, part of a comprehensive treatment plan, and might be preferred for those individuals with factors or comorbidities causing increased surgical risk. I'll show you some of the results from our own series. You can see that it is very effective. The blue bars showing the baseline level of outflow tract obstruction with gradients in the range of 60 to 150 millimeters of mercury at rest or following a premature contraction. And then following the procedure, there's a significant and dramatic reduction in those gradients. Here's the response with respect to symptoms for our first 100 patients in the procedure. Our success rate was 100%. There were no procedural deaths. And there are always risks to an invasive procedure, but our series has been very fortunate that we've had very good success with this procedure. There are some risks, and including one of them being a high degree AV block causing the need for a pacemaker. It occurs in about 10 to 12% of the population. But the results show that patients with severe symptoms, that is class 3 or 4 symptoms, generally at 1 year, there is a very favorable response such that 92% of the patients, over 90%, are either having very mild or moderate symptoms. And this is a very favorable result that's comparable to that result that might be considered for septal myectomy. And those results are sustained over time from a couple of series that I'll show you here. You can see that the gradients, which are shown here in these red and black lines, diminished dramatically after the procedure, and that is sustained for over 5 years of follow-up, as is the response to symptoms. And so when one considers that most patients are class 3 with symptoms to start with, most patients are in class 1 or 2 at follow-up, and that is sustained over the next few years of follow-up in these series. And this slide shows something very important, which is that if one looks at the survival after alcohol septal ablation, not only is it improved compared to people who have no treatment, who have obstruction, and similar to the expected survival for the population, it mimics and is very similar to the survival following surgical septal myectomy. And so it is a very successful treatment that is safe and effective, as is septal myectomy. So with that, I'm going to turn this over to Dr. Kotkar to take over. So let me stop sharing my slides and turn it over to Dr. Kotkar to give a presentation about septal myectomy at Washington University. Kunal?
Thank you, Rich. And thanks, Lisa. Thanks, Julie. Thanks, Amy. I really appreciate this opportunity to speak at HCMA. I'm going to share my screen here now.
Okay, thanks.
Can you guys see my screen? Perfect.
Not
No?
yet.
Oh,
Nope. Try again. There you go.
now. Perfect.
That's it. Thanks.
So, on behalf of Dr. Damiano and myself, thank you very much. And I'm really appreciative of this opportunity to speak about the surgical management of hypertrophic cardiomyopathy. Oops. And for those who remember the wheel and spoke image, which Rich showed in the beginning, this is us in the left corner. I consider this as kind of a happy family, as Rich alluded to that. We discuss almost all our patients. We have monthly meetings where we discuss our most difficult patients, and all of us attend. There's a lot of academic as well as personal conversation. So it turns out to be the best approach for the patients. And as Rich was talking about management of hypertrophic cardiomyopathy, and essentially we come in for intervention when it's talking about obstructive hypertrophic cardiomyopathy. And as Rich said, the indication of septal reduction therapy is when patients have symptoms refractory to medical management, and when you have left ventricular outflow tract obstruction with gradients more than 50 at rest or with provocation. And guidelines tell us the same thing. I mean, the level of evidence is one. It tells us, number one, and which is, I think, in my opinion, very, very important, that patients who are symptomatic despite maximal medical management are candidates for septal reduction therapy, specifically and preferentially at experience centers where these procedures are done commonly. So the outcomes of these procedures are, these are procedures which are good procedures. They have great outcomes, but they have great outcomes when they are done in institutions where they're done very routinely. If an institution does these very rarely or few times a year, the outcomes are not as good. And that's why the people who write these guidelines have made sure that this becomes a part of every single guideline. And again, comes up with the HCMA part where, center of excellence becomes a very, very important thing. We discussed the history very briefly. In 1947, Brock described a case series of muscular subaortic obstruction, and Taylor also described an autopsy series where he showed subaortic obstruction causing sudden death of patients. Many of the good surgeons, Cleland, Kirkland, all of them tried to do some kind of septal myectomy procedures, septal reduction procedures with variable success and not very good outcomes. They had very, very high mortality rates at that point of time. So as everybody said, in 1960, Morrow from NIH came up with a myotomy procedure. A myotomy is essentially a procedure where instead of resection, he initially just incised the muscle and let the muscle spread open. And that itself, and then the muscle healed, it healed with fibrosis. And so essentially the muscle kind of separated out, and that itself caused a reduction in the gradients. Over time, he perfected his technique where he did 2 myotomies and then some resection of the muscle. Over time, an extended septal myectomy, which is currently considered as the gold standard surgical therapy, was devised. So why go for surgical management? I mean, I think what all of us understand here is that hypertrophic cardiomyopathy is a disease which affects all age groups. We have patients who are kids, who are infants, and we have patients who are in the 70s and 80s who come for the first time for septal reduction therapy. And so when we offer surgery to these patients, it is typically when they have already exhausted all other options. They've gone through medical management. Many of them, in fact, have actually gone through alcohol septal ablations and now still have resting gradients or are symptomatic. And so why perform a septalmectomy, or why perform a surgical management of hypertrophic obstructive cardiomyopathy? I think one of the biggest advantages which everybody accepts is what it is called the gold standard, because it has a long-term symptom relief with survival benefit, which has been shown over and over again in all the studies which have ever been performed for interventions performed for hypertrophic cardiomyopathy. These procedures are done by direct visualization of the outflow tract. And it's not just the outflow tract. As Sharon mentioned, there are a lot of other things which you can see with these patients. They have abnormal papillary muscles, their mitral valves are abnormal. And so surgically, these things can be corrected at the same time. So the patients who are having obstruction, not only because of their outflow obstructions or because of their septums, but because of their other issues, these things can be sorted at the same time. Other cardiac lesions, as we said, there are patients who are from all kinds of age groups. So there are patients who have coronary artery disease, patients who are in atrial fibrillation, patients who have other valve issues, and these issues can be sorted at the same point of time. There is no evidence, there is very, very low operative mortality involved in septal myectomies. And to put it into perspective, most other cardiac surgical procedures do have an operative mortality of about less than 1%. But if you look at this paper by Moreau, which was published in 2007, this was the outcomes of 3 of the large institutions performing myectomies at that point of time. And these were number of consecutive myectomies without an operative death. And I'm proud to say that in Washington University since 2009, we've had almost 200 cases with no operative mortality for isolated septal myectomy. So these are high-risk procedures, but we have been doing these procedures consistently with very low operative mortality. This is the same series of patients. If you see the top line, which is dark blue, it shows that when septal myectomy is performed as an isolated procedure, it has 0 mortality in the last 10 years. Most of the patients who have any kind of mortality are patients who have concomitant procedures along with septal myectomy. For example, a patient has coronary artery bypass grafting or the valve replacements or some other procedures like that. Our late experience is also fantastic. We've had mean follow-up of almost 10 years, and almost 92% of our patients are in NYHA class 1 or 2, which means that they have very little shortness of breath at rest, or for that matter, they are almost absolutely asymptomatic at rest. Mitral regurgitation is less than 2+, which means, as Sharon was talking about, the leakage in the mitral valve, which is caused because of hypertrophic cardiomyopathy, even at late follow-up, we have 95% patients who have mild or almost no mitral regurgitation. So in 2021, what are we talking about, right? Maybe the surgical management of septal myectomy has been around for more than 60 years now. So in 2021, what do we talk about? We talk about these three things. We talk about minimally invasive septal myectomy. We talk about surgical therapy of concomitant atrial fibrillation. As Mary also alluded to, one of the commonest rhythm disorders along with hypertrophic cardiomyopathy is atrial fibrillation. And sometimes that is the reason why patients come to the hospital, where there is definitely a correlation between atrial fibrillation in hypertrophic cardiomyopathy and long-term poor outcomes. So the management of atrial fibrillation also becomes very, very important. And then trans-apical myectomy, which I'll touch on right at the end of it. So what are we talking about minimally invasive? We're talking about minimally invasive in the sense we are talking about mini sternotomy approaches. So we know most cardiac surgeries are done to the middle of the chest by opening up the entire sternum and the whole heart is exposed. And that is the standard approach for all cardiac surgical procedures, including septal myectomies. But at Washington University, we have been doing minimally invasive, it is upper mini sternotomy septal myectomies for the last few years. And we published this article where we did about 86 patients underwent mini sternotomy. We only did isolated septal myectomies in these patients, and we compared these two groups. And if you can see, these are really, really small incisions. You can see my pointers. A typical incision would extend from this V to this V, but we only had incisions which are about this many. There's about 3 finger breadths. And this is an actual operative image, which shows that this is the entire incision all by itself. And this is the final scar. As you can see, this becomes very, very important. This is a very small scar, which is typically hidden by clothes. You almost never see the scar. I'm going to show you a small video which shows the upper mini sternotomy approach. So as you can see, this is an upper mini sternotomy incision. Only this much of the patient's chest is exposed. For people who have already undergone this kind of surgery, this might be interesting for you. This is typically how we do all kinds of septal myectomy procedures. And so we are opening the aorta at this point of time, and that's your aortotomy. And what we're trying to do is expose the septum underneath. And this is what we're doing. This is what we're pointing out. This is the septum. This gray thing which you can see here is the hypertrophic septum. So as I was talking about, this is what we see when we're actually doing the myectomy. We see the hypertrophic septum. And when we see it, we're able to take a knife and actually cut it out. I'm going to just go ahead a little bit just so that I can show you what I'm talking about. So we essentially start just to the right of the right coronary, and then we make this large incision into the muscle itself. And this is how we cut it out. And this is the first piece of muscle which just came out. We always measure it because we want to know how deep we have gone, depth-wise as well as length-wise. And this is typically just the first cut. An extended septal myectomy involves 2 cuts. Now we will make a second cut, which is deeper into the ventricle so that we have the entire left ventricular outflow tract exposed. So this is a second cut. And this is what I wanted to show you. This at the end of the procedure, we should be able to see the entire mitral valve. This is what you're seeing in here is the mitral valve. So we can see the entire mitral valve exposed. So that shows us that the outflow tract obstruction has been relieved. And this is the closure of the aortotomy. And this is the heart beating again. So we compared the 2 groups where we had the upper mini sternotomy and the full sternotomy. And what we found was there was very minimal difference in the cross clamp time, which is the time when the heart is completely stopped between these 2 procedures. And so this was a safe procedure to do. Also, the gradients were reduced to similar levels in full sternotomy as well as upper mini sternotomy. The outcomes, which is the NYHA grade, which means how well did the patient feel, were also comparable. In essence, minimally invasive procedures are now considered feasible, and they have the potential of reducing surgical trauma. Other thing which we need to talk about is atrial fibrillation. It's a common sequelae of hypertrophic cardiomyopathy. And it has been known that atrial fibrillation association in hypertrophic cardiomyopathy is associated with higher late mortality. And this is a paper which says exactly that. When you have a patient with atrial fibrillation, their long-term outcomes are, when somebody has residual postoperative atrial fibrillation, even after septal myectomy, their outcomes are not as good as somebody who's not been in atrial fibrillation. So it's very important that the patient stay out of atrial fibrillation to enjoy the long-term outcomes. Well, atrial fibrillation ablation was a procedure which is devised at Washington University. We are proud to be the institution where this ablation technology was devised and popularized. So we felt that we were the best institution to follow our own advice. So our preferred strategy is to go for a biatrial Cox-Maze procedure in all patients who have atrial fibrillation along with hypertrophic cardiomyopathy. And this is just an image showing the lesion set. This is the right atrial lesion set, and this is the left atrial lesion set. This is how we typically perform a Cox-Maze procedure, which is a surgical ablation of atrial fibrillation. And we perform this entire ablation in our hypertrophic cardiomyopathy patients with atrial fibrillation. We recently published our experience of hypertrophic cardiomyopathy patients where septal myectomy was performed along with atrial fibrillation ablation. And we found that 96% of our patients were available for follow-up. And our late results were excellent. We had fantastic outcomes in all of these patients, and most of these patients were absolutely asymptomatic. As you can see, at last follow-up, most of our patients are in the 1 and 2 layers, which means the patient is almost asymptomatic. Freedom from atrial fibrillation was very, very, very good even at 7 years. I just wanted to end on a small note about non-classical approaches, and I just wanted to talk briefly about it. We all talk about outflow tract obstruction in hypertrophic cardiomyopathy, and how surgical myectomy or septal reduction therapy is crucial. It's considered to be the gold standard for therapy. But what about those patients who don't have outflow tract obstruction? As Sharon had mentioned, hypertrophic cardiomyopathy is very diverse in its presentation, not only genetically, but also morphologically, which means there are patients who have outflow tract obstruction, and there are patients who don't have outflow tract obstructions, patients who have apical variants or mid-ventricular variants, or patients who have generalized variants. There are some patients who have apical and mid-ventricular variants who don't have outflow obstruction, but have so much muscle that they don't have left ventricular cavity. And what happens in these patients is typically because they don't have left ventricular cavity, the ventricle doesn't push enough blood, and so they're in heart failure. The general rule is these patients are candidates for heart transplantation. Well, not all of them. There are some patients in which we can perform a transapical myectomy. And essentially in this procedure, what we end up doing is we actually core out muscle from the mid-ventricle and the apex and create left ventricular cavity. And so if you look at these echoes, these are patients who have no outflow obstruction, but they have thick ventricles. And if you look at this image right at the left-hand side bottom, you see that incomplete systole at the contraction, the cavity completely vanishes. So you can imagine that these patients are very, very symptomatic since their hearts are not really pumping much blood. And so what can we do for these patients? We can do a transapical myectomy. And just for your reference, the first procedure which I showed you, which was an outflow tract obstruction release, is done transaortically from the other end of the heart. And this is something which is done from the other end of the heart, which is at the tip of the ventricle. We make an incision at the tip of the ventricle, we enter the cavity, and then we start coring out muscle. And as you can see in this little animation, what we essentially start doing is we create this little cavity here. And as we start coring out muscle, we're able to reach up to the mitral annulus, and then we close this incision by sutures. And so essentially what we've done is we've created a cavity inside the ventricle to support the patient's circulation. Not too many institutions are able to do this procedure. We at Washington University done about 5 of these with very good outcomes. So in conclusion, I would like to say that surgical septal myectomy is still the gold standard for a treatment of hypertrophic cardiomyopathy. And that minimally invasive procedures will further limit morbidity with having the same kind of efficacy with full sternotomy. Surgical ablation, surgical procedures have the advantage that at the time of surgical myectomy, we can do concomitant procedures like atrial fibrillation, ablation, and taking care of mitral pathologies on papillary muscle or caudal anomalies. A Cox-Smith procedure can be done very safely along with septal myectomy to ablate all atrial fibrillation at a time of the presentation. And then thank you very much for listening to us. This is Dr. Damiano and myself. We are the two surgeons who are doing septal myectomies at Barnes-Jewish Washington University. Thank you very much for your attention.
Thank you so much for that. And I really appreciate the thoughtfulness of the detail of the conversation tonight. We've been getting a lot of great perspectives. I am going to remind you that the poll is open, that I was supposed to open at the beginning. So if you would please take the poll. We talked about that before we started and I messed up the poll. We do have a couple of questions pending. I'm sorry I didn't get to that earlier. If you have any questions, please populate the Q&A box down below and our faculty can address the questions in writing, or we can wait till the end of the presentation and we'll handle them verbally. So I am going to now hand it back to Rich, who's going to kind of talk about future and amazing things that are coming. And when he's done, I even have a late breaking happened this afternoon at the HCMA comment about upcoming research. So off to you, Richard.
All right, thank you, Lisa, and thank you, Kunal. That was a great summary with some amazing videos. Wow. Just a couple more minutes here to wrap things up about the end of 2021 and what's on the horizon. And some of you may already be aware that there are a couple of new agents that are being developed for hypertrophic cardiomyopathy. And I find this information very exciting, but I need to read this disclaimer that the following information that I'm going to show is a description of an investigational drug therapy that has not been approved for use outside of clinical trials. In the box, you'll see that there are actually two agents in development. One, the first agent of its type, mavacamten, was developed by a company named Myocardia, now a subsidiary of BMS. So this agent has been in testing for about the last 4 to 5 years and is further along in development, but there is a second agent in testing at the moment, clinical trial testing, called aficamten by a different company called Cytokinetics. So there are a couple of very promising agents, and let me show you a little bit about them just over the next couple of moments. So mavacamten is an agent that interferes with one of what has been discovered, and this information is relatively new in our appreciation of the abnormalities that go along with hypertrophic cardiomyopathy. It interferes with what we might call the excessive contraction of the heart muscle with hypertrophic cardiomyopathy. This diagram shows that contraction is the result of an interaction between a couple of proteins in the heart. Dr. Cresci showed that diagram of the sarcomere, it's called, which is the unit of proteins that when they get together contract and cause the muscle to contract. Well, there's an interaction between one molecule called myosin and a longer molecule called actin, the so-called thick and thin filaments. And when the myosin interacts with the actin, it pulls it in a way that squeezes the muscle. And in a normal state, there are many of the myosin heads that are really what are called a super relaxed state, so to speak. So they're not participating in the contraction, but in individuals with hypertrophic cardiomyopathy, there are an excessive number of interactions between these myosin and actin molecules. And that is a fundamental feature that the heart is actually stronger or the contractility more vigorous. We call it hypercontractility for someone who has hypertrophic cardiomyopathy. And mavacamten is a designed agent, small molecule that interferes with this interaction in such a way that it returns many of those myosin molecules back to their relaxed state and converts this interaction between myosin and actin back to a more normal physiology compared to the excessive interaction in patients who have hypertrophic cardiomyopathy. So there has been a study done, and we were fortunate here in our center to participate in that study called the Explorer Hcm Trial. And it was a very important and well-designed clinical trial of this medication mavacamten, where 251 patients were enrolled. And as is important to understand how effective a medication is, those patients were randomized between the mavacamten at different doses or what would be called a placebo. And the patients were not aware, the physicians caring for those patients, and I was one of them, were not aware of what the patients were receiving during the course of treatment, which was over a course of about 26 weeks in the trial. And the dose was adjusted during the trial to achieve the results that you'll see. There was a washout period for 4 weeks at the end of the study. And you can see that, I'm sorry, after 30 weeks, there was a washout period. So we have results of during treatment and then after the washout period. And then some patients went on to continue taking the drug in what's called the long-term extension trial, which will give us some more information over time about the long-term use of these medications. Now, here's just one of the data points on the use of mavacamten in the study. And what we are looking at is the provocable left ventricular outflow tract gradient, a measure of the degree of outflow tract obstruction. All the patients in the study had a severe degree of left ventricular outflow tract obstruction. That is a gradient exceeding 50 millimeters of mercury. And you can see the baseline gradient averages about 73 to 74 millimeters of mercury, which is a severe outflow tract degree of obstruction. And you can see that on treatment with mavacamten, which is the blue line, there is a decrease in that provocable outflow tract obstruction that was decreasing and then sustained over the course of the 30 weeks of treatment, such that there's a significant reduction in outflow tract obstruction by mavacamten in the study. And the residual gradient, perhaps not down to the level of gradient reduction by myectomy or I'll call septal ablation, but a significant reduction in gradient nevertheless. But more importantly, how did patients feel on the drug? Well, this is a bar graph similar to what you saw Dr. Kotkar showed a few moments ago. Here's the baseline symptom status. Pink color or teal color represent either moderate or severe symptoms. So everyone in the trial has at least moderate and many have severe symptoms. But you can see that at week 14, about halfway through the study, you can see there is an improvement. And by 30 weeks, 50% of the patients or so have a significant reduction so that they're now having only mild or minimal symptoms. And only a small, less than 10% of the patients still have what we consider to be class 3 or severe symptoms. So there is a significant symptomatic improvement on the drug. And it's shown very well on this slide. It may be a little hard for you to interpret, so let me walk you through it. But if we look at a measure of quality of life, and this is the Kansas City questionnaire that's used to determine a patient's symptom status for heart failure symptoms, and we could translate that into quality of life to some degree, that higher numbers are improved quality of life. The red line is patients on placebo. The teal line is patients on mavacamten. You can see that at the stopping point or 30 weeks of treatment, there is a significant improvement in quality of life for these patients. And in fact, Dr. Spertus, who presented these results as part of the national meetings, made a point that this is one of the stronger responses of a medical treatment that he had seen in his experience with respect to improvements in quality of life by medication across many different cardiovascular conditions. What's also notable here is that when the treatment was stopped, you can see that the quality of life and the symptom status declines back to the baseline, really essentially confirming that it is the medication that's doing the work here and significantly improving these patients' symptom status. And the drug was well tolerated in the trial. You can see that compared to placebo, the drug did not have a significant increase in what we call adverse events. There were a small number of patients who, as a result of being on mavacamten, had a decrease in their contractility enough that their ejection fraction dropped temporarily, but importantly, On those patients, there were about 7 of them in the study. When the drug was discontinued, their ejection fraction returned up to even its baseline level. So the drug was well tolerated, which is very encouraging for long-term use. And so if I can just wrap up everything I've said from before and after Dr. Kotkar's presentations, for symptomatic patients with HCM, our guidelines endorse first-line medical treatments, including treatment with beta blockers or verapamil or diltiazem, and consideration of another agent called disopyramide for those patients who are severely symptomatic with HCM and outflow obstruction that is severe. Both myectomy and alcohol septal ablation result in early and sustained hemodynamic and symptomatic improvement with excellent long-term outcomes. But then the promising and very exciting information that we are just now appreciating from these new clinical trial data, both preclinical and clinical studies suggest an investigational agent, mavacamten, and preliminary results with the second agent, aficamten, suggest that they can have favorable hemodynamic and symptomatic benefit for patients with HCM and significant outflow tract obstruction without potentially the need for septal reduction therapy. With that, I will leave it and turn it over to Lisa for any other question and answer period we have. Lisa, take it over. Thank you.
Thank you for that very inspiring and optimistic view of where we might be headed here. I want to give you a couple of updates on mavacamten, just to go over a few key points. We had been talking for a long time that it looked like the FDA would make a ruling on their approval of mavacamten in January. They have requested more information about something called REMS, which is basically safety follow-up when the drug hits market. And they have pushed off the date that they are going to make their decision until April of 2022. I know that was frustrating to some people who were hoping that they might get access to it sooner, but it is coming. And I think it's a good thing that we're being careful about who's prescribing, where it's prescribed, how it's being evaluated. And the FDA is doing their job here and being cautious. So FDA takes a lot of hits for not doing things right. But I think this time, by putting the brakes on a little bit, is going to be a safer launch for everybody. So I know you're frustrated, but hang in there, people, we're getting there. I do want to bring up another clinical trial, actually a couple of clinical trials that we're working on right now at the HCMA. Many of you have answered our Embryo study request, and that is for a drug to be used in non-obstructed HCM. I do not believe that all of the spaces in that trial are filled yet. There might be a couple more. I'm getting an update next week. If you are interested in information on that, probably check an old email from the HCMA and look for the Embryo study. You can look for it online as well. And we can still get your information over to the clinical sites on that if you're interested and you qualify. Excitingly today, I'm finalizing a deal with another drug company called Celltrion, where we're going to be assisting in recruitment for obstructive patients. I need a very, very, very special 4 individuals in the United States with HCM, with obstruction, resting gradients 30, Valsalva 50, or 30 is fine. Doesn't have to go to 50 with Valsalva. Only on beta blockers or on another agent that you can stop for 6 days when you go inpatient for a phase 1 patient trial, where you will be in the hospital for 6 days, having testing done each day. They will bring a friend along with you if you're traveling out of the area. You will be reimbursed very well for your time. They know that this is a big burden for an agent that is an equivalent in many ways to disopyramide long-acting, also known as Norpace CR. This drug is currently being used in other countries. It's never gotten approval in the United States, and it's been on the market for 30 years already in other countries. So it's got a good safety record, but they have to go through the hoops of this 6-day inpatient experience for the first phase of the clinical trial to prove safety in an HCM population, even though they have lots of data from other countries. You're going to be seeing something published from us over the next maybe 2 to 3 weeks. We're finalizing contracts now. So they're looking for people to be hospitalized for those 6 days, probably in January or February. The sites are located in Boston, New York, and LA, and you may even be able to get to choose what site you go to, and they'll pay for all the transportation as well. Look for more information on that. There'll be an entire, informed consent document that you can go through. And if you think you're interested, we can put you on the list. You can talk to a clinical trial coordinator, see if it's right for you. And then in a couple months, we'll be doing their phase 2 and phase 3 trials when that becomes available for a disopyramide alternative. So we're gonna have mavacamten, we're gonna have aficamten, we're gonna have Celltron's company or product. We're going to be treating a lot of medically manageable HCM patients for obstruction with new agents that have less side effects. So yay us, we finally have a lot of clinical trials going on. I'm so excited. More tools in the toolbox. Okay, so that's my pitch for some upcoming trials. Oh, and I'll be speaking to Cytokinetics next week about helping them recruit for their trial in aficamten. So HCMA has been busy with helping get these clinical trials populated. So we have some questions, and Brenda has had them hanging out here for quite some time. So I figure I will start with those because she's been patient. I hope she's still with us. It goes back to Sharon's talk. How do you measure peak systolic strain?
Yeah, that's a great question. We do it routinely in our echo lab. It used to be a research method, but now we do it on every patient. And it actually is a specialized software that our echo machines have. They use a methodology that's based on what's called speckle tracking. So they track the movement, the program tracks the movement of the myocardium, and it generates these numbers for us that show us how quickly they deform. I don't think that all hospitals use the echo machines that have this specialized software on it, unfortunately. But we are very big believers in that. And as I've shown you, really rely on that quite a bit. And so if you come to our hospital for any reason, not just HCM, we will perform this myocardial strain imaging on as part of your routine echo.
Fantastic. Thanks for the answer. If a young adult tests negative on echo, do they still need genetic testing?
Yeah, so if you're saying a first degree family member, I'm going to assume. And so if you have a family member who has hypertrophic cardiomyopathy, then if you are a first degree family member, you can either opt to do, or that person can opt to have genetic testing. And if they have a pathogenic variant or likely pathogenic variant, then you can do genetic testing to see if you are positive for that familial variant. If you are, then you need to be clinically followed. If you do not opt, if your family does not opt to be genetically tested, then you do still need to be clinically followed. So every first degree family member needs to be followed, even if you're an adult. And so the recommendations are that you get a screening echocardiogram at the time of the diagnosis of your family member. And then it should happen again every 3 to 5 years. So as Mary says, it's not a one and done. You're followed every 3 to 5 years, or if you have a change in your symptoms, if you've been completely fine, but then you develop shortness of breath, you need to have another echocardiogram, screening echocardiogram at that time. And then that continues really up until at least middle age, so at least until you're in your 50s. And so we do sometimes see people who have one echocardiogram and then their doctor tells them that nothing more is necessary, but that's really not correct. And that's not following the guidelines.
Unfortunately, we've heard that many times where somebody thinks they have one screening and they're done. Actually, one of the cases in the HCM Academy was a young lady who at 17 knew her dad had HCM, got screened, and it was told it was clear. And at 28, while pregnant, finds out that she actually has HCM and had already had another child, and maybe would have made different life decisions because now she's passed it along again. So, there's really important gems in there about getting out and getting these families screened. even when your family doesn't maybe want to hear you and they don't want to do it all the time. I am finally going to share the poll results tonight, even though I said I normally forget to actually post it, and I forgot to tell you about it. So you can see that there's a number of people here from all over the United States. We don't have any foreigners tonight, but they'll probably be watching us on YouTube later. Most are patients or have a family affected by HCM. We have 3 medical providers with us this evening, 2 members of industry. I think I know who you are. And we know that about 28% of you were diagnosed in the last 2 years. Most of you are on meds. Almost half of you have ICDs. Some have had septal reduction therapy already. Some are dealing with AFib. About half have had genetic testing. That's a good number. And some of you are considering getting an ICD or having septal reduction therapy. So we're hoping that tonight's content was illuminating to help you understand where those risks are and where your decisions can be made. And hopefully we'll get you the information you need to make the decision you're really comfortable in. I'm going to ask a question here. And Christopher, I'm going to kind of take your question and unpackage it a little bit to be a little bit more generalized. So an individual with HCM, not symptomatic, no treatment plan in place, they're thinking of starting a family. What could they do with information from genetic testing that might alter the future?
Sure. So obviously, I think you need to, I would suggest going to an HCM center and getting the full benefit of genetic counseling with both members, both parties, the husband and wife, and any family members who are interested in hearing. But if the family member with HCM has a known pathogenic or likely pathogenic variant causing HCM, the embryos can be, can be screened, and you can select to not have those embryos implanted for fertilization. So that is offered across the country. Obviously, this is a very simplistic sort of statement, and there's a lot of shared decision-making and family decision-making that needs to go into this. And so it's something that really should be discussed, but there is that option available.
We have some amazing success stories with PGD. Some of them are damn near miracles, and I don't use that word easily. We had a young lady who had a cardiac arrest at 16, transplanted in her early 20s, went on to wanting to be a mom. Couldn't carry the baby because of the transplant risks involved with her specific case. Went on to get a surrogate. We did pre-implantation genetic diagnostics. We got her into a trial very early on. So I got the news that the embryo had taken hold and baby was growing. And I got the call about her sonogram on what would have been my sister's birthday, and found out that although they did not plant this, the embryo, baby split, and we have identical twins.
Wow.
And they turned out to be HCM-free identical twins.
That's great.
That's damn near a miracle in this world. I mean, come on. After what she had been through, to have that miracle was amazing. We have other success stories with genetic testing and PGD, and it's a really exciting technology. But you need to make sure your genetic testing is current. We had somebody go ahead and do PGD with an 11-year-old test, and it turned out that there were some VUSs that might have been problematic that weren't tested for 11 years ago. So make sure your genetic test is current if you're going to do that, and work with a very high volume center and make sure that you're getting the right information. It's not 100% accurate to do this, but good centers can get about 90% accuracy, or maybe even a little better these days. So please be careful there. We have some questions in the chat area. If you could put them in the Q&A, it's a little easier to navigate them over there, but I'm going to try to go through some of these. Once one person puts questions over there, then you leave the Q&A box. It's just all gone. Okay. So if you are viewed as being high risk, or you develop heart block post myectomy, when does that decision get made, and when do you put in a device? I don't know if EP or surgery wants to handle this, so you guys can talk it out.
I can try and handle it. It's a great question. Sometimes we do see this after septal reduction therapy. It's hard to know if it is going to be permanent or not in the first day or two. So depending on the stability of how people are and how their heart rhythm is and how their blood pressure are, we'll watch them. And sometimes we'll watch them 5, 6, 7 days. And then make a decision, because at some point you got to leave the hospital and most people want to go home. But part of that decision that we offer an EP is which is the correct device to use. We didn't even get into cardiac resynchronization therapy for HCM, but that is something that always plays in the back of our mind if heart block persists, because we don't want continued pacing to be a potential trigger for future heart muscle dysfunction. So when somebody needs a device after almost any procedure, cardiac surgery, where we ask ourselves, what's the indication for pacing? Is there indication for a defibrillator? And do we need heart failure pacing? So we'll answer kind of the bigger question. You know, we used to think that some forms of septal reduction therapy would reduce all risk of HCM. And of course, any statement that says all is not always going to be accurate. And so the risk still can be there. So sometimes at our center, what we'll do is if Dr. Bach is planning septal reduction therapy, we have a conversation before that procedure to say, what do we think the risk of heart block is going to be? Does this person need a defibrillator? When should we put the device in? And can we do it pre-septal reduction therapy to avoid any potential issues with arrhythmias post-operatively or post-procedurally? But conversely, I'll have the same discussion with our surgical colleagues. If somebody meets an indication for a defibrillator and is going for surgical reduction therapy, then we assess that type of device need post-operatively to say, do they need a defibrillator? Likely, but do they need now pacing support with that defibrillator, and what kind of pacing support? So it becomes a little complex, but we, again, as Sharon talked about, we try and tailor it to the right situation. So it's just kind of interesting that in some situations we'll do it up front, in other situations we'll do it prior to hospital discharge.
Lisa, if I can also add a little bit to that. So, you know, from a surgical perspective, one has to realize that most of these patients who come for septal myectomy have been followed up for a long, long time. So a lot of our patients already have ICDs or pacemakers in them. So that question, you know, is generally answered even before the patient comes to a surgeon, that the patient already has an ICD, patient already has a pacemaker, and that's taken care of. Now, in most surgical series, the risk of complete heart block after a surgical myectomy is pretty low. The risk of a complete heart block after alcohol septal ablation is present, but not very, very high. But the risk of a complete heart block of a septal myectomy performed after an alcohol septal ablation is pretty high. So these are the patients where we know that we are going to have almost a 50 to 60% chance that they'll require a pacemaker at the end of the procedure. Now, just so that everybody understands, once surgery is done, the patient comes out of the OR with temporary pacing wires. So these are patients who are already being paced. And that's where it comes to Mary's point that we'll probably watch for 7 days, 8 days, sometimes even 12 days for the rhythm to come back, because part of the heart block might be because of just tissue edema, not necessarily because the tissue has been cut. And so that typically tends to recover over the next few days. And that's just for the surgical portion of septal myectomy. These are the options which patients do tend to have.
Thanks for the clarification and additional information. So we have a question about what is published on the topic of after diagnosis and episodes of NSVT. Let me see. Yeah, okay. I had to read this a few times. So there's SICDs and there's ICDs. So I don't necessarily think the type of defibrillator is the important part of this question. What do we know about devices and any disease progression or obstruction growth or increase in outflow tract gradient? Is there any connection between EP related issues in the ventricle and progression of disease? Vivek, I think that's what you're asking.
Ooh, that's a good one. And I'd have to say off the top of my head, we don't have a lot of data on this. And part of it, I think, is because when we talked about how the guidelines changed from prior one assessment, and now it's going to be long-term follow-up. Now the onus is on us to collect this long-term data to determine this. And something that we all haven't talked about is a national registry of patients where we can look at these things and adjudicate the data. And especially with these new therapies coming, we need to know this. And we need to know not what happens in the first 30 days or the year, but we need to know what happens 5 years from now after these potential treatments. So there is potential for change. Absolutely. Sharon described, the penetrance and things. So things can change, but do we know any good data on how to kind of counsel and talk to somebody about it? I'm not aware of that. But I think it's a fascinating question, and I think that's a big knowledge gap.
So I completely agree. Go ahead, Sharon.
I'm sorry, I just wanted to point out that the progression of HCM by itself without devices is very unpredictable. And so I think that question is almost impossible to answer, because you would need so many numbers as your control, and you'd have to have sort of a matched person as the control, because we can't really predict the progression of HCM in any individual at this point. And so it's a great question, but it's also a really big problem to be able to attribute the progression to the device, I would think.
So I'm going to hit you all from a different perspective here for a second. And I think this is a really interesting question. So stay tuned. Number one, we are working on moving the internal HCMA database, that's all the information we get from every patient, to a new platform that will allow better research collaboration and also allow those same data fields to be shared through all centers, so we can all put the same data in our own silos and then cross over and share it. So stay tuned, that's coming really, really soon, and I'm very excited about it. But this particular question, I almost want to go back in time for a little bit to be a little optimistic here and show you what we were and what we are. So we really didn't know how to well document gradient change in time when it was time to go to myectomy. We got better at that. We now can watch those numbers. We see when pressures are changing. We understand when it's time to act. Boom, we go to myectomy. We were able to look at all the data and Barry Marin's amazing work to figure out what are the risk factors in sudden death in HCM. So we did that, and we figured out how we can get in front of that. And we came up with a therapy for that. We're figuring out what genetics mean for family members and when we can get in front of that. So if you go back 60 years, we didn't know any of this. So what's next? Well, now we know that the minute the ejection fraction starts to drop in HCM, we're watching more closely. We're making more timely referrals to advanced heart failure, so people like me and Amy can get heart transplants in time before things are too late. So we're finding all of these. It's like HCM is on a mission, and we keep jumping in front of it and making it go right and left. So we're getting closer to being able to answer these questions. But the only way we're going to get to those harder questions, when do we know EF is going to drop? When do we know obstruction is going to occur? Is to look at mass data, masses of data over decades and decades of life experiences with different genetic mutations, no genetic mutations. We need to look at it all. And we're in a day where we can start to really do that, because we have hundreds of thousands of years of lives of people with HCM that we can follow. And we just need to get that data a little bit better organized, which takes time, money, and skill. And we're working on putting all those together so we can actually accomplish this. And I'm really looking forward to what we're going to do in the next 6 years. It's not a 20-year cycle. If we can move a couple of mountains in the next 12 to 24 months, I think we're going to go skyrocketing ahead in our understanding in the next 6 years. I see Rich sitting there smiling, going, "Oh, Lisa's on fire tonight." So yes, I'm excited. We are at a good time. So be excited. but we can't answer the question yet. So I took a question I couldn't answer and I turned it into a rah-rah session, didn't I? Okay, anybody else have comments on that? No? Okay. I believe we're going to now say farewell to our Facebook watching friends, and we're going to turn off the record feature to give people an opportunity to ask questions that are not going to be kept in eternity on the internet. So we're going to say thank you and goodbye to Facebook.